Yes, sir, we are live now.
Good evening. I am Dr. Omkar Swami on behalf of MCure Pharmaceuticals Limited. Welcome you all in first live program for Andhra Pradesh and Telangana on fight against STEMI in era of COVID. We all know the COVID has changed our life, and we have struggling to many aspects of succumbing the pandemics currently. So to discussed on the preclinic and clinic thrombosis, selective PCI during COVID area, and experts on the consensus on the management of a STEMI during COVID time. We have designed this program, and we have very lucky and fortunate to have a very eminent faculty today evening. Let me join and welcome Dr.A.Sreenivas Kumar sir, who will be moderator for this program, and I also welcome Dr. Ramesh Babu sir, Dr. N.S. Ramaraju sir, Dr. P. Chandrasekhar sir, and Dr. A. Vasant Kumar sir, who will be participating as a panelist in this event today evening. So Dr. A. Sreenivas Kumar sir, who will be overall moderator for this program. Sir is the senior consultant cardiologist and director of cardiology and clinical research at Apollo Hospital, Jubilee Hills at Hyderabad. I'm sure everybody know sir, and I need not to introduce in detail. So sir will be taking us through all the nitty-gritties of fighting against the STEMI in the era of COVID. With this, I hand over this program to the sir and take your pardon. Thank you very much.
Yeah, good evening, everybody. I think I'm happy to be sharing this webinar with all of you. On these tough times, we should appreciate MCure for taking this initiative in spite of all odds. Our continuing education as well as taking care of patients should continue. And some of the nitty-gritty, some of the new things which you're facing in this COVID challenges and how it will change our management of acute myocardial infarction, such things will be discussed. And I'm again one happy on another front, though we are stressful for this COVID. I'm happy on another front that both Andhra Pradesh and Telangana together, I think we are doing this program, which we were very fond of before, but for various reasons it had done. If we were together, I think NIC data collected after Maharashtra, our state would have been the second in number of procedures and number of cardiologists. Though we are artificially divided, but still all should continue to do such programs. I was very particular to have Dr. Ramesh Babu sir, who has pioneered this work in that part, and others like Dr. Chandrasekhar, very seniors, and Vasant Kumar, Ramaraju. Thank you all for joining. And I thank MCure once again for making this possible. And with this, what the flow of events, what we thought would be, we will have a brief talks basically on hospital thrombolysis and pre-hospital thrombolysis. And then Ramesh Babu sir will cover on in which particular scenarios we still would like to do PCI in this, even in this COVID times. And we'll stress and spend more time on discussion regarding some interesting aspects, what we are coming to know in the scenario of COVID times. And I would also share and start with some interesting news in the discussion, and then go on to the various aspects and topics of discussion after the lectures. I think, can I have the next slide for introduction of? Yeah, Dr. Ramesh Babu sir is actually senior cardiologist, chief cardiologist, and managing director, Ramesh Hospitals, Vijayawada. I think other city cardiac center is now as Astor City Cardiac Center. All of you know him. I need not introduce him. And I was particular that he should be there involved in this program because he has pioneered this work in that part of state when everybody was struggling around in Hyderabad. He took a bold initiative way back, went there and created history, and he has brought this service to benefit of all the needy patients there. And he also a lot of not only academic and cardiology achievements. Now he's an entrepreneur, and that's why I requested sir to spend some 5 minutes time in the end for the benefits of youngsters. That I'll keep in the end for the interest's sake. And can I go to the next slide? Dr. N.S. Ramaraju is other speaker today, and he's chief interventional cardiologist and director at Bolneni Hospital, Rajamandri. He was assistant professor in Nizams. Thank you, Ramaraju, for accepting in the last moment also because of some change in the schedule. And he will be talking about preclinic and in-clinic thrombolysis. Obviously, MCure would be focusing their attention on this aspect because they're molecule of tenecteplase, that is Elaxim. I feel Elaxim company is very clever, and we Indians are that way supposed to be. Ramesh sir also did it in Vijayawada. We Indians generally are supposed to be clever and making the difficult situations for opportunities. I think MQ saw that, and they saw a little more role for tenecteplase, their molecule in this change scenario, and they immediately rushed to make this more popular, and rightfully so. If you're doing it for right indication, it's always a welcome. And not only the standard indication, there are some peculiar new indications which come up in these COVID times. We'll get it on to the discussion. Can you go to the next slide? Dr. Chandrasekhar sir is now just came across. I was knowing him as a professor and head cardiology. Now I was also told he became principal of medical college. Congratulations, sir, again. And thanks for sparing your time to be as a panelist for this discussion today. Next slide. Dr. Vasant Kumar, again, interventional cardiologist at Sri Vijay Durga Cardiac Center, Kurnool. The idea was to have people across from the various parts of the both states. I also wanted somebody from Karimnagar. Dr. Ravindra Reddy was closely associated with me in doing this pharmacoinvasive protocol. But he's a COVID warrior now. He's attached, and since last 1 month he didn't go home. That is the flight of doctors who are very seriously involved in that. Karimnagar, though it is now officially on the notes, it doesn't come with too many cases, but daily he treats a lot of these patients, and he couldn't join. So with this, I think with this introduction, I would now request Dr. Ramaraj sir to present, because thrombolysis is the one, and then we will go on to selective PCI, to present regarding his lecture on the thrombolysis. Over to you, Dr. Ramaraj. Ramaraju, my father's name was also Ramaraju. Remind me of my father. Anyway. Go ahead.
Sir. One minute, sir. 1 minute.
Yeah, no problem. As he is getting ready, sir, you started, all of you started, Dr. Ramesh Babu sir, you started working normally now?
Yeah, actually even now, our team is coming, members, we are divided, 3 cardiologists on one day, 3 cardiologists on other day. Alternatively, they are coming and doing the OPD and cath lab work.
Okay. Now you started the elective OPDs also.
Yes. With social distancing, minimal, with appointments only.
Okay. What is the state in Kurnool, Dr. Chandrasekhar? Can you unmute him?
Sreenivas Kumar.
Yeah, we can hear you.
So the problem is actually we had a COVID pandemic early. Now we are getting cases from Maharashtra. The Valasapuli antaru kada.
From our district.
So one day it was only 2 days, 3 days back, 50 of them are positive in Kurnool district. So
I think tests are also being done more liberally in
more liberally, and AP is the number 1. Among the most of the 3rd or 4th in the country, actually. We have done more than nearing 3 lakhs tests. So we got Kurnool also, we got 2 labs. We are getting another 1 lab.
Okay.
So we got a TrueNOT, RT-PCR. As a principal, I am in charge of the labs and this one.
So anybody wants to get the testing done, it is being done?
Yes, easily done.
Now my
and
challenge,
probably, I think in Telangana they have stopped doing tests and all. Somebody was telling.
Yeah, no.
But here in AP, number of tests are done basically.
And the challenge I feel is in this era, basically you want to do a procedure, you should be able to. Now I think he's on. We'll discuss further after his talk. Okay, I think you can go on, Dr. Ramaraj.
Sir. Good evening, my dear senior colleagues and participants. And thanks for giving me an opportunity. And I took the position of Dr. Murthy from Vizag because he dropped in the last minute, and I was asked to speak about the role of ACS management, in particular to thrombolytic therapy in the COVID era. We all know from the last 1 month, we forcibly, because of the stage 2, stage 1 or lockout, we all forcibly, especially in the private practice, all hospitals, majority of the hospitals, except for a few emergency branches, we stopped working in the COVID era. And even the hospitals in our area only used to meet, only few hospitals, especially in Rajahmundry, only our hospital used to work and take up the cases. And even in handling the case also, we used to encounter a lot of difficulties. The reason behind the reason is, one is in the early days of COVID, when the first 2 phases of lockdown, government used to insist that all patients with SARI-like symptoms, like those patients present with acute breathlessness, pneumonitis, suspected lung signs, all patients should be referred to COVID hospitals only. So in such situations, it used to be very difficult to handle all acute coronary syndromes patients who presented with pulmonary edema or lung signs, or the hemodynamically unstable patients, or pre-existing patients who are pre-existing coronary artery disease patients also. When they come unstable, it used to be very difficult to handle them, because it is very difficult to prove whether the patient is positive or not. 1 minute, sir.
Ramaraju, we professionals should be careful in talking, because the administrative in charge of testing, Dr. Chandrasekhar, is also in the group.
Sir.
I'm just kidding.
Okay. So when we see, this is a routine statistics, when we see the epidemiology of STEMI in India, there are 2 important registries, especially in India, CREATE registry and Kerala registry. And we see 40 to 60% of the presentations of acute MI are with the STMI. So we all know that young age populations and the early age of onsets and other aspects are the common things here. And but particular scenario in the COVID era, the main problem especially is the delayed presentations. In the last month, when we the cases which you used to see are majority of the window period more than 48 to 70 hours. The reasons are many. One is lack of transport, lack of basic healthcare facility, lack of doctors in the nearby to diagnose whether it's an acute coronary syndrome or something else. Quacks used to see patients, RMP doctors, and they used to either misguide them or not able to diagnose them, or patients, they by themselves, they're having the fear of going to the hospitals because of the COVID symptom, COVID fear. They used to present very late in the presentation, and even those presenting very late, presenting with acute LVF or unstable situations, the hospitals are not in a state to accept these situations. So these are some of the problems we encountered during the COVID era in handling the patients. But surprisingly, not only here, I don't know whether it's universally now. We after seeing the slides from Mount Sinai Hospital, it has shown that many in the many countries there was a sudden drop down in the incidence of coronary artery disease (STMI) during the COVID era. It's very surprising. Even a lot of WhatsApp messages and a lot of circulated showing that corporate hospitals now are thriving, lack of patients. What happened is people are living very healthy. There is a drop down in the death rate like that. It is surprising. A lot of reduction in the acute MI presentations last month in the peak COVID era. Peak in the sense during the stage 1 and stage 2 lockdown period. The reasons are many. Probably because of the improved mental or physical health, a balanced diet, no junk foods, no pollution, or like that. Maybe these are some of the reasons, and which attenuated the physical, psychological, chemical, and gustatory triggers of acute coronary syndromes and STMI during COVID era. Probably have reduced the occurrence of presentation of acute coronary syndrome and STMI during the peak COVID era. As we all know, the reperfusion strategies, the PCI is the gold standard. and next is thrombolysis, or pharmacoinvasive therapy, that is lysis followed by early intervention, PCA, in those patients where there is a delay in the transfer to the PCA center for more than 1 hour, it has to be implemented. So there are certain modifications which we need to implement and adopt in the present era, in the COVID era, because there are certain issues. One is saving the patient and saving ourselves and saving the infrastructure. See, yesterday in one cancer hospital here, one of the elective admission, the patient got positive. So they completely stopped the hospital and vacated the patients, and all the there in the hospital were immediately sent to the COVID testing, and they stopped all the elective surgeries, OP patients, and the particular patients. So if you are treating any patient, we have to treat them as a potential possible positive for COVID patients only. We have to take utmost precautions. So it is not merely saving the patient, but at the same time saving ourselves, our organization, because instead of taking risk for one patient, we cannot lose the entire hospital. So these situations has to be taken into consideration in management of during COVID era. So utmost important is prevention. Prevention is the only aspect. We have to train our staff members, we have to train ourselves, we have to adopt all the necessary precautions to prevent cross contamination in a potential from the patients, either positive patients or potentially positive patients or suspected patients. For this, we need already a lot of campaigning is going on, a lot of training is happening in all the staff members, and especially healthcare workers, and a lot of protocols are changed in the hospitals, like social distancing, usage of sanitizer, disposables, PPEs, etc. So strict adherence to the universal precautions measures is very crucial in the healthcare settings, not only to protect patients, but also to protect ourselves and the organization. So what are the new challenges in managing the STMI patients in COVID-19? One is patient delay. As we already discussed, there is an undue delay due to either existing national lockdown or lack of transportation facilities, or lack of available the first medical delay in the first medical contact. And second thing is, to know whether the patient is positive or negative, it's very difficult there, because the rapid tests, whatever the government is supplying here, they are not that much reliable. And to get a indirect test, the other two modalities of tests, what we are now doing, especially in the APR, one is TrueNat and other is an PCR test. So for a TrueNat, minimum 4 to 6 hours it takes, and for a PCR, a lot of waiting is there. It takes minimum 2 to 3 days. So currently, the non-availability of tests, whether it's a patient is a proven positive or not, it's a difficult issue. So medical person cannot take, especially on an emergency basis, to handle the patients in an emergency with invasive procedures is a big task now in a COVID era. And also there is a limited centers to do this. Another important thing is troponin values. Troponin values are usually elevated in COVID-19 infection with even subclinical myocardial infection, need not be myocardial infection. So we cannot just diagnose acute coronary syndrome based on the troponin level estimation. And second thing is, we always need to assess the risk-benefit ratio in acute MI intervention with reperfusion against the infecting the hospitals or our co-members or ourselves. So always risk assessment should be there when handling these patients. So what are the cardiovascular manifestations in COVID patients? We all know respiratory symptoms are the dominant symptom, but apart from that, cardiovascular manifestations are also the leading cause of death in all the COVID patients. For this, one of the most common presentation is acute coronary syndrome, but need not be acute coronary syndrome, and myocardial injury without myocardial infarction, or patients can present with simple chest pain mimicking myocardial. There's myocardial mimics myocardial infarction with vague ST changes and elevated troponins. These are also some of the manifestations of COVID patients. They can present with the focal myocarditis simulating STMI, or they can present with stress cardiomyopathy or with coronary spasm. And many of the COVID positive patients are having a mild myocarditis, who are asymptomatic with mildly elevated troponin levels and with the self-limited illness. So what are the reperfusion strategies to be adopted in STMI patients in the COVID era? Should we go as usual routine by going a primary PCA, or we have to do a step backwards to keep a balance between the patient care and protecting ourselves. So, how do we balance these two issues? So, primary PCA strategy is a time intense with extensive resource utilization, including trained cath lab staff. We'll be exposing our staff. So we are exposing the hospital as well as the staff. There is a potential risk of exposure, and also there is a potential delay, because once we have a plan to do a primary PCA, until unless we are sure that whether the patient is COVID or not, positive or not, we cannot be safely take the patient to the cath lab, because once you infect the cath lab, there is an every chance, or suppose if the patient proves to be positive while in the hospital admission, the entire hospital goes into lockdown, or there will be a lot of problems will be there. So in order to protect the cath lab, save the patients, we have to adopt certain via media strategies in this, especially in this COVID era. So immediate reperfusion using the thrombolytic or fibrinolytic therapy can mitigate some system delays. And also we can buy some time. Suppose if you thrombolize the patients, especially in the first 3 hours, you can buy some time before doing an invasive procedure, so that we can subject the patient for COVID testing. And suppose the COVID testing comes to be negative, we can safely go ahead with invasive therapy. Leave alone us, if you see, the majority of the US labs, as the COVID spreads, US cath labs ponder fibrinolytics for STMI. They are more preferring to lytic therapy rather than primary PCA. So we can see the benefits in the stream trial, which showed the pharmacoinvasive therapy, that is early thrombolytic therapy at the first point contact of the medical personnel, and shifting earlier this invasive therapy, you used to perform fibrinolytic therapy with the immediate referral to PCA lab and subjecting the patient for a PCA within 6 to 24 hours later. But now this adoption, this method of thrombolizing the early hours, first to 2 to 3 hours, and taking the time to test the patient for whether he is COVID or positive or negative, gives us time to do an angioplasty safely within 24 hours by giving equal safety and equal benefit to the patient. We can see this trial, this slide showing almost equal efficacy of pharmacoinvasive therapy versus primary PCA. So this results, we can now in the COVID era, we can take advantage of giving primary thrombolytic therapy, testing the patient for COVID, and subjecting the patient within 24 hours after COVID testing to invasive therapy to protect the healthcare personnel as well as the hospital. So whenever in the field staff, suppose if they encounter an acute coronary syndrome in the emergency department evaluation, this is the a protocol that is adapted, recommended. We should focus on detailed physical examination, and with the pulse oximeter, chest X-ray findings. And nowadays, with whenever there is a CT surgery unit present, immediately CT chest screening to see any peripheral lung deposits are infiltrations are there, which are sized of COVID. And also suspect, you see, taking the history, you see whether the patient has any recent history of travel or exposure to COVID patient, or symptomatology sized of COVID. If they're there or not, we have to see. And if it is possible, now in the present scenario, we are not having any test to do rapid tests immediately, as though we are doing HIV or HCV in the emergency department. There is no provision like that for COVID-19 testing now, but probably in future, maybe in 1 or 2 months, probably we may get some tests like that to selectively differentiate whether the patient is COVID positive or negative in the emergency department itself. So until unless then, we have to be more cautious in deciding whether the patient is COVID positive or not. So this is the one of the algorithm recommended by Mount Sinai Hospital. So any patient presenting the STMI, if there is a COVID test positive, subject the patient, or if the patient is not positive, the test is not available, if the patient has known COVID exposure or history of size of cough or fever or chest X-ray, we have to subject the patient for thrombolytic therapy, and everything is negative, we can subject the patient for primary PCA. Those patients where there is a hemodynamic instability or PCI should be given as a rescue modality after the failed thrombolysis. So primary PCI recommended in the COVID era presently now in those patients who are unstable, hemodynamically unstable, those having a cardiogenic shock or unstable, or as a rescue method. So we all know reperfusion is a primary strategy in STMI. So selection of the reperfusion strategy is we already discussed. PCI gold standard, but may not be now in the primary setting until unless we have a rapid test available which can reliably detect whether the patient is positive or not. And pharmacoinvasive therapy may be a better option in the present COVID era to buy some time. And so what are the advantages of thrombolytic therapy? This is the routine recommendations from the company made slides. Thrombolytic therapy has greater benefit if it is given within 1 hour of symptom onset, or preferably, and the results decrease after 3 hours. 3 hours. But the disadvantage, it has more stroke incidence, reocclusion rates, etc. Thrombolytic therapy decision making here. We all know streptokinase is an age-old molecule. It's a it's not fibrin specific compared to the other molecule, but still nowadays in the ESC guidelines they have removed streptokinase as one of the therapeutic as one of the thrombolytic agent also. Now they are insisting on reteplase or tenecteplase. But here when we are discussing about the utility of thrombolytic agent in the COVID era, when we are opting a thrombolytic therapy, what are the advantages and disadvantages? The main issue is whenever a doctor, maybe a resident doctor or nurse or whatever it is, who is treating an acute myocardial infarction with a thrombolytic therapy in an ICU era, they should be adequately protected, because every patient during thrombolytic therapy can deteriorate. He can develop a cardiac arrest, he can develop an acute LVF or sudden decompensation, anything may happen. So any decompensated patient, suppose if it happens to be positive, can spread the disease very rapidly because of the aerosol spread. So any medical persons who are attending the COVID, any patient during this COVID era should be completely protected with PPAs during handling the patients. So the main in the COVID era, the idea of selecting the lytic agent is to minimize the contact time between the patient and the medical attendants. Here the main issue is with the streptokinase, our standard recommendation is to give over 60 minutes. So meanwhile, we all routinely practice give over 60 minutes in the 100 ml NS, periodically monitor blood pressure, whether sister, junior doctor, or a resident or a consultant or all will be staying with the patient for 60 minutes. So staying for 60 minutes, either with a COVID positive patient or COVID probable patients, increases the contact spread between the patient and the contact medical person. So that is a main disadvantage, especially with the streptokinase in the COVID era. But now, especially with the Oroxiri era, we have no other option except to use streptokinase even nowadays. But if given an option, we have to go for a lytic agents with reteplase or tenecteplase. But even with the reteplase, we have to give 2 boluses over 30 minutes apart. But the advantage with the tenecteplase is a single shot we can give over 5 to 10 seconds. So this advantage probably will be, we can take this advantage during COVID era because we can minimize the contact for the medical personnel and patient to reduce the spread between the patient and doctor. So this is, as we all know, streptokinase is an old molecule. Only the reperfusion rates will be around 45 to 50%. And whereas coming to the other molecule, the reperfusion rates are more, and resistance to PA1 is it's not resistant in streptokinase, and they're resistant to the tenecteplase. And these are the recent ESC guidelines where they show here in this interesting slide, where the show is, suppose if there is a diagnosis with STMI, the fibrinolytic therapy should be given as early as possible as 10 minutes, and it should be completely as early as possible 10 minutes. So suppose if you are planning with Q streptokinase, it takes minimum 60 minutes, and even with the reticulase also it takes 10 minutes. So probably the bolus injection with tenecteplase may be having some advantage in reduce, though the efficacy is almost equal to reticulase with the tenecteplase. So in the latest recommendation ESC, they have removed streptokinase, and they're recommending alteplase, reticulase, or tenecteplase. Tenecteplase can be given as a bolus dose. And we can see some of the important studies, especially the Indian studies. This is one small study. Interestingly, it was published from Anantapur, Andhra Pradesh, where Department of Medicine has studied nearly 100 patients, and they have shown the ST resolution up to 92 to 94% with tenecteplase. And this is multi-center study. Another multi-center study from which was published in Indian Heart Journal, where R.K. Jain, Nair, Sachimurthy from they all are involved, and 15,222 patients were analyzed, and they have shown high successful thrombolysis with tenecteplase compared to other molecules. So results are encouraging with tenecteplase with 93% reperfusion rates, and with less incidence of hemorrhagic complications. This is a meta-analysis published in Lancet studying the different thrombolytic fibrinolytic agents, the efficacy of different thrombolytic agents, and it has shown that the bleeding complications are less with the tenecteplase compared to other molecules. So taking the all this into the consideration, let me conclude that treat all the patients of acute coronary syndrome as potential COVID positives in the present era, until unless proved otherwise, and proper safety measures for staff members in the hospitals should be given priority. At the same time, we have to keep a balance between the patient safety as well as hospital safety, our staff member safety, and our safety. And invasive method of management probably is a preferred option, because we can buy some time to test the patient whether it's approved, we can use positive or negative. And primary PC should be reserved in the present scenario to hemodynamically unstable patients or only in the rescue conditions. And the tenecteplase is the preferred of the thrombolytic, the spelling mistake, thrombolytic therapy, probably because of injection, because it can be given as a bolus injection, and it also has high efficacy with low bleeding complications. And apart from this, when we are handling along with STMA, non-STMA patients, the recommendations also came that non-STMA handling, we have to early invasive therapy should not be adopted in the COVID era. These patients should be stabilized, and until unless mandatory, these patients should not be subjected to angiography revascularization on an urgent basis. So coming to the NSTMA, we have to be more cautious. Optimal medical therapy, stabilization, and only invasive management if the patient is symptomatic or fail to respond to medical therapy only. In the COVID era, we have to go for the invasive management. Thank you.
Thank you, Ramaraju, for covering all the aspects of thrombolysis, not only thrombolytic, but you also touched upon some of the important aspects of primary PCI. Partly did Dr. Ramesh Babu's job also. I think we'll have more discussion about other elements of NST, elevation MI, and things like that. And some other interesting aspects which we see in COVID era also we'll discuss in the discussion part. I think now I request Dr. Ramesh Babu sir to present where all we still need to take help of primary PCI in spite of all the tough times in the COVID era. Over to you, Dr. Ramesh sir.
Yeah. Thank you. Thank you, Dr. Sreenivas, and my colleagues, Dr. Ramaraju, Dr. Chandrasekhar, Dr. Vasant, and the MCure organizing committee for arranging this webinar, combining both Telugu states, as Dr. Sreenivas was mentioning. It's a good meeting point, and we welcome the participants also. So Dr. Ramaraju has nicely put a case which is true to a large extent, wherein the fibrinolysis has got a greater role in STEMI PCI in the COVID era because of the resource intensiveness and a lot of other issues which we'll be seeing, and try to just project the data, global data, what is happening in the past 2 months with regard to STEMI PCI, vis-a-vis even the admission rates, and what people have been recommending, and what we have been doing in our chain of hospitals. So wherein we have almost 25 cardiologists, and most of us are not even occupied, 40% of the time what we were doing before the COVID, as most of our colleagues are. So, in fact, I am passionate about this primary PCA when we started in 1996 initially, and then in the past decade or decade and a half, we have been doing. The acceptance has become more, and we have been doing. And also in this era, I'm showing this slide because the telemedicine is being talked much more in the past 2 months than what it was. Though we have started in 2014, and so far we have given in about 25 telemedicine centers which we have in the 4 districts. Though we have given free consultation to 80,000 patients, it was just routine and then non-communicable diseases and tele-ECGs where we were advising even thrombolysis to the local practitioners. And now in the past 2 months, there have been more number of calls. We have a central command station where we are receiving 1,000, 1,200. We communicate with the people for consultations or, video conferencing and all. And as you see the data, nowadays all of us are hearing 2 terms. One is the isolation and the other is quarantine. So there have been a lot of discussions, debates amongst our national groups of cardiologists, and also the realistic numbers. And to some extent, the media channels have started it, saying and joking that, so no hospital visits, no number of deaths have come down. So is it really needed what they were doing? All the cardiologists are the medical personnel because most of the hospitals look empty. But still, if you see the statistics, mortality statistics, it has not gone up. To a large extent, yes, the trends of primary PCI have come down significantly all over the globe, as we see even in our setups. Whereas the admissions pertaining to the Northern California data, where you can see as expected, the acute MIs also have significantly come down, and COVID-19 patients has gone up. And it's not surprising because of several reasons. The admission of myocardial infarction has come down significantly to the tune of almost 50%, whereas the admitted patients, most likely because of the presentation, which is quite late, it's almost 3 times compared to the usual ICU or, the survival, the mortality figures after acute myocardial infarction. And all of us have been listening to this, and is it only the fear? If you see the factors, if you analyze, it is partly patient behavior and emotional reaction to an unforeseen ailment, which is really, frightening to almost everyone. And then, for the fear of getting infection when they go to a hospital, or of course the lack of awareness. And then surprisingly, we have seen that the family support, which was much better earlier, in these circumstances, most of the times, the support is not that much, especially when there is a very, very serious ailment and the patient is getting infected, and then even the family members are afraid. to go near and to help beyond a point. I think this is, at least in certain areas, it is much more. The disease has come down significantly. So is it because less of stress? All of us are sitting at home, no stress, no peer pressure, no office pressure, no work pressure. And then definitely probably the incidence of smoking has come down, and probably more number of people have started doing some yoga exercises. And then they're sticking to the medication more regularly compared to what they were doing when they were busy and they're having busy social life, office work, and then a lot of other pressures. Then the hospital factors. So what all of us have been facing, how we should take patients in the emergency room. Way back in almost in March, second and third weeks, we had a drill and tried to assess and predict what will be the future in the next 3 to 4 months. And we have trained our teams, as we'll be showing you in Guntur and Vijayawada. So the acute care pathway, so trying to screen the patients in one emergency room and then taking after adequate screening, which still, of course, we must be missing some silent carriers. So doing the routine temperature record, history from travel and the temperature, and then a chest X-ray if there is any mild cough, and assessment, and then taking to the second emergency room, as we have 3 emergency rooms in Guntur facility, which I will be showing what we have been doing with our patients. And then the triaging has definitely changed, as my friend Dr. Ramaraju has mentioned, and the protocols and more inclination towards fibrinolytic therapy, especially in the odd hours or when the cath labs are busy, and especially the night times where all the, it takes longer time for the people to come over to the cath lab. And then probably, yes, though every case has to be seen differently, I must tell you in the initial 1 to 2 weeks of lockdown, wherein fear was prevalent amongst the employees, the nurses, even our consultants, there was a little bias probably. And after 2-3 weeks, everybody got adjusted and probably mind is tuned and fears are gone. And we are doing around 50% to 60% of our workload in the past 6 weeks or so. So, and then what is the impact of this? The behavior and all, of course, the acute and long-term patients will definitely lose more muscle by the time they reach us, and they'll definitely have more complications, mechanical complications, and there will be definitely increase in burden on a lot of other things like surgery, multivessel PCIs or arrhythmia management devices, CRTs, and more heart failure patients. So these are the main concerns as we have been discussing, the number of patients attending emergency systems. So in our setup, we have developed telemedicine as informed, and we were giving 40-50 video conferencing calls, apart from a lot of hundreds of the telemedicine calls attended by junior medical officer and if necessary by the senior medical consultant. And yes, in our setup also, there is a slight increase in thrombolysis compared to STEMI, the PCI. And of course, keeping in mind the future challenges, the short and long-term complications. And as Dr. Ramaraju mentioned, it is more important to protect our healthcare personnel, right from the emergency nurses, ICU nurses, and our consultants and the junior medical officers. And when there is a doubt whether the patient will survive or not, probably better not take the risk of taking the patient, ventilating and doing all these things. Of course, every case is to be individualized. And when the chances are less associated, lung lesions are there, probably to err or to go for more conservative therapy is the principle which we also have been adapting. And also the patients who come without infection, if they're exposed to some of the silent carriers who are admitted in the hospital. So we have to take necessary precautions in the the distancing, and then seeing that the patients, whenever it is possible, to make them wear the mask. That is one important aspect. And also to create or to instill confidence in our staff. We have given almost 400 of them in Vijayawada and Guntur put together N95 masks, though we know that these are not required for, these are required only for nursing staff who are directly exposed to an infected patient, not to a suspect. A 3-ply mask with and a cover with a cloth mask is sufficient, but just to give confidence, and we have provided them all visors. So all ICU and then even the front office staff, we have provided them in the March month itself, so that the initial fear which they were having in the initial 1 week, slowly they developed confidence, and now most of them are very, very confident. We trained them enough. We have a very strong infection control team, wherein there are quality champions for NABH accreditation, JCI accreditation. So we have strong teams. And then that's important. And this is, of course, the factors, the clinical phenotypes. The most importantly, as you know, if it is a pure pulmonary, without evidence of any EKG evidence or symptomatic or biochemical or biomarker evidence of myocardial injury, if it is a simple pulmonary, and if it is a straightforward cardiac without the other features of hypercoagulability, then the microthrombosis, all these things are not there, then it is easy to handle if it is a pure cardiac or pure pulmonary. The major problem comes when there is mixed cardiac and pulmonary subset, wherein there is some patch in the lung and some breathlessness or cough in the patient presents with acute coronary syndrome. So that is the segment where probably bias in the decision, clinical decision, and based on the resources available, we have to be cautious in our approach and see what best can be done to the patient. And then, of course, there are several hosts. These are all hypothesized, because there is a lot of infection, the penetrance, and the disease course so far remains so unclear. Dr. Sreenivas and other my colleagues would definitely agree that there has been, we have never seen in our 35 years of practice, or almost 75 we joined medicine, almost this is 45 years now. So we have never seen such an uncertain ailment either in the history. We have heard about plague, smallpox, Spanish flu and all, a lot of other flu, SARS, MERS, etc. But this seems to be something different. The penetrance, the transmissibility, it seems to be so high, and it was missed initially. It was felt that it is only transmitted from the animals. I was also thinking in the initial 1 to 2 weeks, till it spread the whole globe in no time. And this is the fastest transmitted disease with so much of uncertainty. And coming to the cardiovascular disease, there is higher incidence of so-called the class type 2 myocardial infarction, wherein the supply demand is much more troublesome, and there is a combination of ruptured atherosclerotic plaque, the microthrombosis, and myocarditis factors, DIC, all these things, and a combination of hypoxia, dyselectrolytemia, these things. So there is such a great confusing clinical picture, and every patient is different, and you are stuck with protection of your healthcare personnel and doing the ethical, going for ethical approach to the patients. We are really struck, and this is where myocarditis is supposed to be there. Almost 10 to 20% of patients either silent or which is not picked up even by routine ECG, X-ray, and even echocardiogram also. And sometimes, of course, there are venous and arterial thromboembolism also, and patients presenting late, as we see, probably already in Italy and other places. People have started presenting. Cardiologists seem to be getting busy with the late presentations and more, severe coronary syndromes with the LV dysfunctions and all. That's what we hear. So, and of course, the utility of various equipment and the echocardiogram, what we have been doing, and the management of STEMI remains the same if it is a straightforward case. But if there is a combination, then the treatment modalities we may have to change a little bit. And this is all cytokine storm and mostly hypothesis and some of the patients. The ARDS also seems to be because of the cytokine storm and microthrombosis, not unlike the other types of ARDS which we routinely see. And surprisingly, in all the cases of myocarditis, chest X-ray and CT, most of these times these were reported normal in most of these case reports. So yeah, we have mentioned, Dr. Ramaraj has mentioned risks and benefits of these things. And of course, you have to select the subset, and when there is definite high risk patient, and we have to go for emergency. And certain like, STEMI PCAs we have seen almost around 20-25 STEMI PCAs we have done in the past 2.5 months. And the staged PCA we used to do in the index hospitalization on 4th or 5th day. But in this COVID time, we have our tendency is to postpone the stage PCI till the patient develops symptoms, or at least postpone it for a few weeks. Of course, the CTO, the role of PCI and all is not there in this era unless patient is extremely symptomatic. And so these are, a lot of confusion again about the drugs, different countries. And as you hear, WHO has put a halt a few days ago to the Solidarity trial, wherein there is the hydroxychloroquine role. That arm is held back, and the Data Safety Monitoring Committee of WHO is doing a lot of analysis, and it will come out by June 10th to suggest whether chloroquine can safely be given. And a lot of other drugs have been tried, antiviral drugs, with a lot of interactions with the statins, anticoagulants, and all, and then the greater risk of QT prolongation, especially patients who have the tendency for QT prolongation, or surfacing of Brugada or long congenital QT syndrome. And a combination of azithromycin and chloroquine is more feared, and you have to have a continuous monitoring of ECG, and then if there is more than 20% increase in the QT interval, we are supposed to be very, very cautious. Yes, we have seen methylprednisolone being tried in certain patients. Recently, one of our very close family friends had, 4 or 5 days fever. Again, the same thing. People are worried to go to the hospital, seek medical advice. He did not tell anybody. He was having fever for 4 or 5 days. Then we did a CT scan. It was showing multiple patches. So he went into cytokine storm, and fortunately, with IV methylprednisolone, in the past 3 days, he's showing significant improvement. Almost CRP went up to 108. So likewise, these are, of course, still the WHO doesn't recommend any particular drug which is found to be very safe and advisable because it is too short and the number of studies are not sufficient. So just quickly, I will show what we are doing in our setup. So we have a central command station manned by 6 people. We handle around 1,000 to 1,200 calls, either giving appointments or listening to the patient's complaints. And in our free telemedicine clinic centers, our medical officer will keep advising them in non-communicable disease. And this is how our patients are received. We have 3 emergency rooms in our Guntur setup, wherein the patients are initially screened with the history and all these things. If there is a doubt, they are put in the contagious emergency department. From there, X-ray or if necessary, CT scan is done. And if there is any evidence, they are referred to the COVID hospital. And so they are evaluated thoroughly before shifting to the wards. Fortunately, none of our staff of almost 2,500 and odd have got infected with this. And we don't know whether some of the patients are silent carriers. As you know, 80% of the patients are silent carriers with COVID. So, and then this is how we conduct the echocardiogram. Our people are trained enough to do the routine investigations. And of course, these are the steps when we have a strong suspicion, a moderate to strong suspicion. And this is Dr. Harita at Guntur. She's a senior cardiologist colleague of mine. She's how see the donning, and we have another room for doffing. Donning and doffing actually used to be done very, very cautiously. It is believed that during doffing, most of the times you get infected unless you follow the steps carefully. And we have a negative pressure system in one of our emergency rooms. We converted this, keeping in mind that we have to take some of the patients of this COVID may come. So we have done it in March, second week or so. We were well prepared for that. So this ER emergency room is meant for people who are suspect or where, and still you keep them for 2-3 hours before excluding, before safely taking them. This is towards the roadside, and so that the other part of the hospital is not affected. And these are some of the patients, see whether to go for, thrombolytic therapy and or PCI, especially when the patients are young, and then this patient, like large RCA with PCI, probably you do better. And similarly, there's another young patient out of blue who came, last month, this month itself on 16th. So we have done a dual stent for this patient here in Vijayawada, and this is another patient where the LCX, and then the patient was in shock. So we had to put a IABP and do the stent. This is another patient. We have done few emergency CABGs also in these 2 months, probably I think three or four at least in Vijayawada. And these are the types of the patients where they were in shock and presented with left main. So we put IABP and then send the patient and operated safely. This is another interesting 28-year-old female. She was having some vague complaints, came to the ER. ECG was not showing much change. So we sent her for CTCA. CTCA was showing, surprisingly, 28-year-old female. This was the lesion. But otherwise, with the ECG, with the clinical picture, we would pass it off as atypical pain. And then because we use CTCA, we have started using CTCA also more frequently. I'll show you this. And this patient was that, and then since she was having significant symptoms, so we had to stent this patient. And this is another young doctor recently, a few days back, about a week back, came again with pain in the chest and then radiating to the left arm. We were not sure whether it is cardiac, non-cardiac, but then even drop one value was, just borderline. So we went ahead and did this CT angio, which was showing a mild lesion only. But still, of course, we have put him on antiplatelets, asked him to come back, and then this is only 30-40% lesion. So he's a young doctor, probably within a week, few days time, he'll go back to his work. And this is how the CTC also optimal utilization, and especially even if this patient had a borderline elevation or twice or thrice normal, when it doesn't fit into any particular territory, we would still send him after stabilization for CTCA rather than going for an invasive angio. As you know well, the troponin can be slightly elevated still without obstructive coronary artery disease, which can be defined with the CTCA, and we can avoid unnecessary exposure of our people. So these are all the cath labs which we have. We have enabled, shortly we are going to have an RT-PCR certification eligibility from ICMR. We have acquired, and these are all the machines. And we have very strong hospital infection control team trained by our strategic partners, the Astrodium Healthcare. We started using this for quite some time to disinfect all our OPD chambers, and then patients who are discharged in both the hospitals. So even just 15-20 minutes of this is sufficient to disinfect, and then we keep moving this in different rooms because we can't have. And then there are the Philips ultraviolet C are also available. We have got in all the places. So this is how we won't say that we are 100% prepared to take all types of cases and treat all types of COVID cases, but just protective measure, taking care of steps for our healthcare personnel, that is much more important. And then unfortunately, we have a lot of medical colleges in and around. So they are working, they are being, utilized as for quarantine and isolation. So this is where I stop. Still, the challenge is there for the next 3 to 6 months. We don't know. Nobody knows how far, and then whether it is changing its strain pattern, lineage, and whether the vaccine will work, and then it becomes more intelligent than us, changes its, form and all. So this is where I stop, and I again thank the organizers for providing this opportunity to interact with my colleagues and also the participants.
Thank you, sir. Thank you for showcasing the various facilities of the hospital and showing us how you are taking care of the patients. I think now we will have some discussion regarding the various aspects of this disease, as well as slightly do some justice to Elaxim also in our discussion. And some chat questions have come, we will also take them. But before we go on to this, I think in your discussion as well as Ramaraj sir's discussion, it was mentioned that cases are coming down. What is the status in India? We did collect from our end that in India too, among the various hospitals which participated in the survey, there's about 58% drop in the ACS and acute MIs. We particularly in Apollo also have seen, I think they're coming to regular admissions, which used to happen about 1,000 plus. Now they've come down by 30% in March and then further come down by another 20%. So about 50% drop. And obviously you can understand non-cardiac emergencies, road traffic accidents and other things could come down, but even ACS, MIs have come down. I think you have proposed the various reasons which are thought of, but most important I would feel in young patients, probably stress, which is the most important factor. Stress of competition, stress of performance, corporate hospitals doing the other things, all that is gone for us. So that itself could go a long way, along with healthy food and lifestyle habits and yoga, meditation, what you all told. So it's a positive thing, but sometimes other critics could argue what these doctors are doing, nothing is come down. In fact, it is better, okay? But it is not so, because in late stages, actually patient coming little late presentations, and we have now started seeing some complications like ruptures of producing MR and VSDs, which are not seeing before because of late presentations are coming to shock. Those things also could happen. I think before we go on to further discussion, I think we can hear a few words of comments from Dr. Vasant Kumar and Dr. Chandrasekhar, who were in the panel before. You want to say any few words, Dr. Vasant, before we go on to the discussion points? Can you unmute Vasant Kumar, sir? Hello. Yeah, I think you can talk. Yeah.
Hello. Yeah, Dr. Sreenivas, Dr. Ramesh, Dr. Ramaraju. We are the one who are mostly giving the thrombolytics. Our percentage of doing primary PC is not as big, because mostly we have credit patients or government sponsored schemes where unless it is rescue, we don't do primary. Only paying primary we do. So most of the times what we are giving is streptokinase, and in non-affordable group. Streptokinase, once we give, we usually wait not as 3 to 24 hours. We usually wait if there is no failed thrombolysis, or if you require only rescue angioplasty, we are doing. Otherwise, it is delayed or deferred angiogram and angioplasty. Regarding the thrombolytics which we have right now, I have used all tissue plasminogen activator. I've used retiplase. I've used chenectiplase of various brands. I think when I was hearing to other discussion last 2 weeks, some of the hospital doesn't know how to give thrombolysis now. The residents of those hospitals, like how to give tissue plasminogen activator. But fortunately, Elaxim, they don't have to have that because it's a bolus dose, 10 seconds, less than 10 seconds, and you don't have to wait for the result. And within 30 minutes, most of the times, you know whether it is a failed thrombolysis or whether it is not going to act. And depending on that, we go for facilitated angioplasty. That means you are doing an angioplasty within 2 hours or 3 hours, or a pharmacoinvasive approach where 3 to 24 hours. Regarding the retiplase, I think only disadvantage is it has to be given twice. That means you give a bolus, wait for 30 minutes, again give thrombolysis, and then wait for the result. But otherwise, giving the tenectiplase is very, very useful and easy. And most of the times now, with not only this COVID era and earlier also, if it comes in the middle of the night, I don't do angioplasty. I give tissue plasminogen activator or tenectiplase in the night. Take them for angioplasty subsequent 6 hours. Only thing, if you give streptokinase, I wait for 6 to 8 hours if there is no problem. And regarding the usage of these collateral drugs, other drugs, like we have to give low molecular weight heparin or heparin along with tenecteplase or retiplase. Either if you go by ESC standards, you give 30 milligrams of enoxaparin IV bolus, and followed by 0.75 or 1 milligram depending on weight. And one thing we should all remember is, if the patient is more than 75 years, it's better to give half dose tenecteplase or in elderly people more than 75, 80 years. We don't usually give the 0.5 milligram per kg body weight. You can reduce the dose. And if you give streptokinase, don't give heparin or low molecular weight heparin immediately, because this is compared to tenecteplase and retiplase, it has got a long action. So our intervention as well as giving heparin should be delayed depending on the circumstances. Thank you.
Is Dr. Chandrasekhar there?
I think, sir, there is a connectivity issue with him. We are just trying. So.
Okay. I think, thank you, Dr. Vasant Kumar, for covering those practical aspects of lysis. And all of us should never forget, though, these molecules are good enough to immediately work in 80% of the time. But as you stressed, it should be followed up with giving low molecular weight heparin. Otherwise, the reocclusion rates are also seen quite a significant number of patients. That's the advantage of short actingness. One way advantage is there's no problems while doing procedure PCI required later. On the other hand, if you don't follow it up with the low molecular weight heparin, the occlusion rates could be little more. That's where I think primary PCI scores over, where we can offer a definite therapy, which is immediately. But in places where lysis is not available, obviously there's no choice. We have to give it. And out of the lytic therapy drugs, I think we are now clear because of usage advantage as well as effectivity, and tenecteplase is quite useful. And some of the newer things, newer utilities, I would say, are probably newer clinical scenarios in which tenecteplase is being used in this COVID scenario, COVID period of pandemic. One, I think many of you, for want of time, might have missed it, but non-cardiovascular, some other presentations, like young patients coming with, because somehow there is a mismatch or deranged clotting and lytic mechanisms in these patients. We do see young patients coming with thrombosis, and we do see patients coming with stroke, and we also see patients coming with pulmonary thromboembolism leading to RV dysfunction, hypotension. And I remember recently that acute stroke, one of the young patients, when this molecule was given, it worked for both probably. He could have some STD changes. We're not sure whether it is MI, but he had a stroke. Now our neurology colleagues give this molecule. They come very early. It worked there. Another thing is pulmonary thromboembolism, one element where I feel it works a lot. Immediately patient, once it is given, even little flow comes and patients' blood pressures improve, and patients improved significantly. As you said, it gives us time, buys us time in this era of COVID, where we have to wait till you get the reports, unfortunately. And then that's how we are buying time and still saving the patient's muscle. As Sir pointed out, some of those clinical scenarios where you have a large MI, ongoing pain, then probably patients having some mechanical complication or hemodynamic instability, probably you would go directly and do the procedures with all PPE and other precautions. And if Dr. Chandrasekhar comes live, please tell me. Okay. Then regarding the other, some of the peculiar presentations, any of these peculiar manifestations, any of you have seen coming with COVID infection, sir, in your place?
Yeah, we have seen one patient with inferior MI-like feature, complete heart block.
Okay.
Then asymptomatic, and with the COVID positive. Not mine. I have discussed with my colleagues in government hospital, which is a COVID hospital.
Yeah.
So there they managed conservatively, and I think the patient survived.
Yeah.
So this
any peculiar
manifestation
you have seen, Ramesh, sir?
So far, a cardiopulmonary combination I haven't seen.
Yeah.
Or because ours is a cardiac hospital in Vijayawada predominantly, so mostly they come with
I think the rules also say that once you are COVID positive, you are supposed to send to the COVID hospitals. Is that the same in your place?
Correct. Yeah.
Previously, it was like that in Hyderabad too, but of late, I think they're not able to manage there, and they give some permission for this.
So we have to close our hospitals also.
Hospitals to manage.
Once,
that rule is changed now, sir. Ramraj also was worried. So. That once you get a COVID patient, the hospital should be closed. I think that they relaxed now, fortunately. and you clean that area, and then probably you can still continue to run the hospital and taking the precaution. That is changed, fortunately. Just for the sake of viewers and benefit of everybody, to remove this fear complex of whether they would get COVID infection if they come to hospital, because very important for them to come on time to the hospital to take treatment. So what as Sir mentioned, in his hospital also has separate emergency departments. Many of the hospitals, I think, they are trying to segregate both infective patients and suspicion itself fever clinics. Apollo being a little bigger place, they have a separate building too altogether, where fever and ID block is totally separate, and that has become full now. They don't get beds now in that place. Slightly on the disease appears to be on the rise. The only challenge which we face as clinicians is we don't have immediate testing. So as a bypassing that, because to avoid that, probably what we are doing is get a HRCT done, which is supposed to be a little more. Though obviously sometimes patient could have without lungs being clean also have a symptomatic infection, but that's what we can do it in the absence of PCR testing. And if patient of acute ACS where we want to do a procedure early, so that being taken for a HRCT, and then once the lungs are clear, then still we take precautions for PPE and then take the patient for procedure. And then especially we had to force to do it in 2 of the patients where lysis was given elsewhere and then shifted to our place because of ongoing pain. I remember immediately those 2. But I think, as you all said, protecting our cath lab staff and personnel and the proper cleaning of the equipment and lab immediately after is important. And as we don't have negative pressure cath labs, that's a challenge. But I think with existing scenarios and wherever is required, all doctors are struggling. As I mentioned, some of the doctors like Ravindra Reddy in Karimnagar are not going home because they have elderly parents who could get infected. That is how doctors give a lot of service in these tough times. But I think though face-wise many people appreciate it, but we are a long way for us to get further benefits like hospitals and various other troubles happening. I think is Chandrasekhar online? No. And then I think regarding the other aspects of Ramaraju was wanting to say something?
Yeah. So what about the testing facilities in our other districts and in Telangana, sir? Because in Rajahmundry, we are fortunate to have, fortunate or unfortunate, we have 2 COVID hospitals, one in the government side and other is a medical college. And where we have a testing for TrueNat facility is there. And especially in the initial days, as Dr. Ramesh sir said, there used to be a lot of staff problems. Where staff used to be so panicky, and we used to run with almost 20 to 25% staff members with the entire hospital. But of late, in the last 1 or 2 months, we have sent almost 200 samples, suspected samples, by collecting swabs. We trained our chest physician helped us, and we trained some of our doctors to collect the samples. And we, in the last 1.5 months, we have sent almost 200 to 250 samples for the TrueNat test. So these are all the suspect patients with presenting with pulmonary edema, pneumonias, or acute influenza-like illnesses, or sudden deterioration in the cardiac patients with lung signs, CT showing some suspect signs. So all these patients came out to be negative. So by seeing all these negative patients, the staff, they got really positive feedback, and they are not that much scared of.
We should all be aware, Ramaraju, we should be aware false negative is around 35 to 40% with TrueNat.
Yes,
even
sir.
with, so we should not get a false sense of security.
No,
This,
sir.
because that's what
TrueNat. No,
But anyway,
TrueNat,
something is better than nothing.
Yeah,
Rather
something
not
is
having
better, sir.
anything like in
And second thing
Telangana,
is TrueNat.
something is better than
TrueNat,
nothing.
if it is negative, yeah. TrueNat, if it is
The
negative,
problem-
negative, sir. Only if it is positive,
the
you need to
problem
be
here is
confirmed with PCR.
medical legal issue. One
Hmm.
hospital in Kurnool district has treated one unstable angina in the night. Morning, the consultant has seen, said probably you need to exclude, go to place where the test is done. Meanwhile, the patient collapsed.
That should not be done, sir.
That should not, I mean,
Those problems
things happen.
happen in this situation,
Happen.
difficult times.
So,
I wanted
avoid
to.
that. I mean, you should have a testing center where our sample should be accepted.
Yeah,
The other day I did for a physician. So I sent the sample because he's a physician from a hospital, government hospital. His sample was tested and it was negative. But everyone cannot go and test like that.
I think if we had Chandrasekhar, we could have taken what is the system, how the tests are being done in the governmental setups.
Yeah.
Fortunately, we lost the connection, it looks. What is happening in Hyderabad is basically, as Raju was asking, we are supposed to send all the samples to either to Gandhi Hospital or to CCMB and the Nizam's Institute and IPM. None of the corporates were given are allowed to do the testing. Though of late, after the court decision, one of the private labs, I don't even remember the name, which was not there before, started doing collecting. But by and large, it is not available in the corporate setup. But we send samples from here to Nizam's and then get the report and plan the procedure next day. And if it comes positive, they are being shifted inside to the deep into the more critical ICU and where all the facilities are there. Otherwise, patient is coming back to the regular ICU. I think we'll take some questions because we are running out of time. Some of the questions because we shouldn't disappoint all the participants who went sent the questions. I think which thrombolytic drug is preferred in the COVID-19 era? This is from Dr. Jayanti, Hyderabad. Obviously, we are here to discuss what is the best molecule. I think because of rapid, if you're not about efficacy also, the ease of giving, as Raju said, you can't keep the patient, suppose you suspect and you have to protect yourself before shifting. That also is the ease of administration is also good, and that is also applicable even in this difficult COVID times, I think. Other thing is, can the cardiologist in city advise thrombolysis or phone to general physician the remote town? I think Dr. Lakshmikant is asking. I think that is all Dr. Ramesh also showed. Many of us now before this also were getting ECGs and WhatsApp and various other modalities, and we were advising. I remember many patients coming from Siddipet when we collected some data about like this 204 patients data we collected. Many of the young patients who had bradycardia, hypotension, streptokinase couldn't have been given. This drug is given immediately. Patients BP picked up and they were shifted later. Though they had a normal course, that's a different story. But we were doing it. I think I don't know about what is the medical legal aspects of it. We are doing it in the good interest of patient. I feel saving patients is of top priority. I think when everything goes fine, nothing should come in between. And that is accepted, I think, permitted to advise. Provided only thing is you have to caution the physician to rule out contraindications to thrombolysis. Like sometimes when the patient has very high blood pressure, to give it, sometimes they could develop bleeding problems like cerebral hemorrhage, things like that, or some recent stroke or trauma history that I think you should ask the doctor to check. And if it's not there, I think then given. Again, I want to stress that when you're advising like that, it is very important for them to be followed up with the low molecular weight heparin, then shift these patients for the primary PCI. And other question is, what is the usage of antiplatelet drug which is to be given? Again, previously it was thought that only clopidogrel to be given along with aspirin. Now we have data with ticagrelor also that it can be used even along with the lysis. And prasugrel generally we don't use because of it has more bleeding tendency. And another question is from Dr. Omkar Swami. Is BNP useful within 24 hours of acute MI? Dr. Ranganath asked, he sent it from Omkar again. Is BNP useful in 24 hours of acute MI? Generally, BNP is more done in the sake of heart failure type of setups rather than acute MI. Probably troponin and CPKMB, when they are prognostically very high levels, it indicates bad prognosis, it is done. But when you're suspecting acute MI without any heart failure present, generally BNP is not used. But if you can have in COVID, one of the presentations could be heart failure presentations in these patients, and then probably very high BNP levels, it should alert you. And then similarly, troponin values, also when they're sent. Initially, some of the cardiologists were infected, sir. I think Ramesh sir must be knowing. They were sending referrals to cardiologists in other countries, I'm saying. And cardiologists were not aware of this COVID infection, going and seeing the referrals without taking proper precautions. And many cardiologists got infected. So, but troponin,
Italy,
yeah, and the troponin values could be little deceptive, as covered in one of the talks. Little elevations could happen even without myocardial infarction, but we need to correlate everything by echo and other things, and then take these patients for PCI, especially not to just risk the staff when you have some minor elevation of troponin. And as also told, non-ST elevation with their hemodynamic stable, again, we need not disturb the staff and make them infected. I think they could be stabilized. And any other, I think that we are not able to take question and answers. What is the administration doing from Dr. Chandrasekhar? I thought we could ask him some more pertinent questions. Regarding the lysis, pharmacolysis strategy, Dr. Ramesh sir, you cover multiple hospitals and patients do get shifted from your telemedicine centers to present center. Can you recollect any of those dramatic examples where this drug could save? As I've mentioned, one of it, and where you did further follow up with this?
Yeah, in these 1.5 months or earlier from telemedicine.
Earlier also.
Yeah, definitely. So we had sent a patient who had in Reperfusion where ECG was sent by tele ECG, and we were seeing here medical officer at the time patient had ventricular fibrillation at the time. So he was cardioverted on the advice because the doctor there was trained, and then they gave the thrombolytic drug, and then patient was shifted. He was saved. Likewise, the travel time whenever it is more than an hour, definitely nowadays I think this is one good thing which is done after this COVID. The perception and the acceptability of telemedicine has gone up, and the recent acceptance of telemedicine even by Niti Aayog and all. Now legally also, when you advise, but telephonically you can provide fibrinolysis. That's going to that will go in a big way to save probably several lives. And all these molecule people, the MQ and other people should focus on peripheries, and we should evolve a system where more and more fibrinolysis is done in the periphery, especially odd hours, and then patient to be shifted to the tertiary care.
How far it is advisable to promote peripheral thrombolysis, because it is likely to be misused, because the treating doctors will not be having a defibrillator first of all, until unless they are trained to watch important rhythms, or they are trained to defibrillate or to monitor rhythm only. As far as I feel, it is safe to thrombolyze, because if they are not in a state to handle at least reperfusion arrhythmias or ventricular fibrillation or ventricular tachycardia, it will be a disastrous to the patient. Of course, the benefit will be more, but at the same time, the treating doctor, the doctor who are giving a thrombolytic therapy should have a minimum knowledge of the basic arrhythmias and how to handle them.
Yeah, what do you say, sir? Sreenivas, somehow the incidence of ventricular fibrillation has come down in our ICU, even when they are receiving tenecteplase. Of course, more and more patients we are taking early to cath lab and all, but otherwise also the incidence is less, and probably the benefit of giving it within the first 1 hour, a thrombolytic drug like tenecteplase, which will act very fast. Probably it is worth. Of course, as you said, they should be trained. They should have a defibrillator. They should be trained. But without that also, even now, if you see the multiple centers where at least MBBS doctor is there, and on the advice of a tele-ECG and a tertiary care doctor, we are available 24/7. And in odd hours, especially if you give within the first 1 hour, the mortality benefit and morbidity benefit. Of course, occasional patient may have reperfusion arrhythmia, whether it is really reperfusion or whether it's natural course, but we have to take that risk. But we have to train, and we have to see that all the primary care centers are equipped with defibrillator.
Ideal scenario is what you said, sir. But in general, also the advantage of tenecteplase is again that you just give this molecule as bolus injection and shift the patient. I have collected data about 208 patients in which we did that from peripheral Siddipet, Karimnagar, and various other areas to Hyderabad. We lost only 4 patients out of this 208. The 4 patients also died because they are in cardiogenic shock, and there itself they died, never in the transfer. So though these arrhythmias happen, I think God is great. Once the artery opens up, generally less likely to die. But if the patient, some of them, these 4 patients who died out of these, they never picked up there itself in the center, they died. That is a problem. But as far as possible, if streptokinase, it is a more of a worry of monitoring, because you have to take it for 1 month, 1 hour, and you need to be careful. But this other advantage of this molecule is that facilities where it's not there also, many times a patient's lives are saved, because otherwise if defibrillator is not there, if they're not given, patient would have died with hypotension arrest. As you said, it may be right, but if possible, I think they can be immediately given and shifted. What is more important is giving it to the right patient. You have to identify right acute MI or not. Then I think that is more important than having all the monitoring facilities. If it is there, it is good. I think Dr. Chandrasekhar has joined back. Sir, we were having some administrative questions also for you, along with your comments on this pharmacoinvasive strategy. You want to say anything on the pharmacoinvasive strategy, and then we'll ask you some questions regarding the various testings, the modalities which are being done in Kurnool. Are you able to talk to us now? Yeah. Yeah.
As you know that even Andhra Pradesh, actually we are planning to start the STEMI project at Andhra Pradesh.
Yes.
With the help
I
of,
wanted to
Dr.
tell it in the end. Anyway, that even both in
no,
Andhra
that is the
Pradesh and
one thing, but the
Telangana,
only thing is
they are
that
giving lytic drug, this tenecteplase.
pharmacoinvasive therapy is definitely is useful, and we have been using the relaxum, that is tenecteplase almost for 3 to 4 years. Almost we have 300, 400 vials have been used in the cardiology department in the general hospital, because we got a supply from the APHMDs and all. So definitely the complications rates are less with the tenecteplase when compared to the streptokinase. Earlier we used to see a lot of cases of streptokinase going into sudden arrest or going into sudden hypertension and arrhythmia problems. So definitely, but only thing is it is a cost effective, and of course if it is available in the hospital, we have started using it, and not less than 10 to 15 vials we use every month in current, because our admission rate usually before COVID period and all, almost 10 to 15 acute coronary syndromes, and out of which almost 5 to 6 cases we used to thrombolyze, of course, non-exclusion of MI and all. So this is definitely is mandatory, and we started almost when Thomas Alexander has come back 1.5 to 2 years back with the help of Ramesh, and we have started this first STEMI national STEMI conference in Vijayawada. I think it has to be picked up, this primary PCA, and also the patients, this also pharmacoinvasive therapy is at the right choice. As you know that the culprit vessel is patency of the culprit vessel is very, very important, and definitely this will go a long way.
The other advantage which we have noted, sir, Ramesh sir and others we have seen is once this drug is given, though if it works, it works. If it doesn't work, we will know it also immediately. It is like a thrombectomy. Suppose if it doesn't work in about 20% of patients, we can always shift the patient to do the procedure because we do the radial. That worry of femoral hematoma, all that is also not there, and more of fibrin specificity and the short-acting nature helps us to avoid the complications which happen during PCI. Other thing what I have noticed is, though some patients continue to have pain, when you have taken these patients for PCI, there's already the TIMI 0 becomes at least like TIMI 1. There is a track scene. So they use the easy to do procedure like wire passing all also could become little easy. And if not total normal flow, at least it helps us in doing the PCI procedure little more comfortably. Obviously, some large thrombus burden patients happen when the patients come very late. That is where is the challenging time. If they don't come within 6 hours to 12 hours, if they come 12 to 24 hours at the worst period where you have a lot of thrombus burden and we need to take multiple runs and still slow flows happen, all those is a challenge. But out of all the things available, patient education, coming on time, and we giving this molecule on time, and then if required, occasional patient doing the PCA also as a pharmacoinvasive strategy goes a long way in saving patients' life. I think all of us agreed on this point that there's no doubt this tenecteplase molecule is a useful value addition, and there's a lot of advantages over streptokinase, as already mentioned, because of fibrin specificity, short half-life, and then probably it is more of opening rates are much higher, and then patients do better, and very minimal complication rates of like side effects of hypertension, other things are much less. I think this is what they wanted to hear.
Yeah, Srinivas, can I just put a one minute?
Yes, sir.
I think this platform should be utilized. We should ask the MCure people to talk to the top management. And at the national forum, since you and Dr. Chandrasekhar are there, who can influence the national cardiologists also, we'll take it on an aggressive mode and promote this telethrombolysis, which is not that difficult because there are many MBBS people who are in the periphery, they know what is thrombolysis. And if we take this support, if we, with what business level, like for example, now they are selling X number, if the number of sale goes up by 10 times, which is very much possible if we resort to telethrombolysis, can they bring the cost to 25% of the present cost? And can we encourage our cardiologists to promote it in the peripheries and telethrombolysis? Now it is legally acceptable now. Telemedicine is no more looked upon. See, at one point of time, Karnataka was saying, even the Calcutta was saying, don't go for telemedicine advice and don't never, thrombolyze like that, even few months back. Now that it is legal and it is logical, I strongly feel that we can save several thousands of lives every month if you do adopt this. The only thing is price. If you can break it down.
This price thing, sir, I don't know. I think it's accepted in Andhra Pradesh also. STEMI Telangana program is also started, sir, where the government, in the government hospitals, they have selected 4, I think, centers, and where the tenecteplase is given in free of cost in the government general hospitals, and then the patients are shifted to. Only problem is that you shouldn't be commenting like this, but they have got to come to Usmania and Gandhi hospitals alone here, where there's some reluctancy in doing primary PCI program. But otherwise, tenecteplase usage in STEMI Telangana, KCR government has accepted giving this relaxin tenecteplase, unlike the streptokinase which we are facing. I think in Andhra Pradesh, I don't know, is that project accepted in Andhra Pradesh also? In Tamil Nadu, it is. I was told that they are trying to do it, and one center, one state in the north also they did it. That cost issue will go out, and I think if more usage happens, then cost will come down. Ramaraj, you want to say?
Yeah. Regarding the more utility, I think our Chandrasekhar sir is quite influential to. He can influence Jagan to include this in the Arogyasri package, giving a more package for Arogyasri patients for a tenecteplase. Once it comes into the Arogyasri, we can see what is the fate of the stents. Earlier they used to sell for 75 to 80,000 to 1 lakh. Now they are selling for a minimum cost. So if it comes into if the government includes it in the Arogyasri, naturally the company people will reduce the price like anything. I think they'll reduce by say 70 to 80% also. Because then utility will increase like anything. Chandrasekhar sir can take an initiation to abolish streptokinase and the thrombolytic practice in Arogyasri patients and to go for better molecules. And to add one more comment also, Chandrasekhar sir, I didn't recognize you because you're not in the suit.
Sir, Dr. Chandrasekhar,
we are used to see you in suit only.
We wanted to check with you regarding what is the status of testing which is happening in your hospital, because there were some questions happening whether they could send the samples and what is the COVID testing policy.
First thing I will answer to Ramaraj, because whatever is there acute MI without thrombolytic therapy is 10,000. With thrombolytic therapy, with angiogram package is 30,000. So we have to, whatever maybe the cardiologist now in Andhra Pradesh, we are giving only streptokinase. I don't think people are ready to give tenecteplase because it
That's why he's requesting you. That's why he's requesting you.
The main problem with Arogyasri is, sir, is the patient presents with hypotension, unstable patients, where we are not in a state to do a primary PCA or not to give a thrombolytic therapy. These patients are landing in major problems.
Patient is in cardiogenic shock. I think 70,000 or 80,000 package is there. So that is also can be. But only thing is the hospital stay will be prolonged and a lot of complications also will be there. Anyhow, we'll
cardiogenic shock again. They're insisting for IABP, sir. Suppose if the package is for IABP should be kept in these patients with ventilated patients. So IABP for this they give 70,000. With that again we cannot give more latest thrombolytic therapies. So we need a separate package for this.
In fact, after the new government has come, we have even that Thomas Alexander's wife is a classmate of P. Ramesh. Is also the present secretary to Honorable CM of Andhra Pradesh. And we started actually 2 months back. We have started this.
Anyway, I think there is some connectivity issue with Dr. Chandrasekhar. Dr. Vasant Kumar sir, and you want to say any final comments before we close?
I think if you can't use streptokinase, if you can afford, I think without any hesitation, we should give tenecteplase, give bolus, and send to a place where proper procedure can be done. If they can't afford that also, we used to give urokinase and with 15 lakhs dose or minimum. But most of the times what you see is Now it is available again, urokinase. For some time it was not available in the middle. So they used to give 5 lakhs, 2.5 lakhs, which is not an adequate ideal dose.
Yes.
So if available, Alaxim is the choice of thrombolytic we should use in our current practice.
Thank you, sir. Dr. Ramesh, sir, any final words?
Yeah, that's all. I think definitely, as people were mentioning, the tenecteplase usage must go up to save the lives. How you take up, we have to take up in a big way.
Yeah. I feel this molecule, which is done by MCure, is a local molecule, as our Prime Minister said, we should make it more popular, be vocal about it, make this a global brand. When I went to Africa and other countries, there's hardly any molecule available. I was telling these people to make this molecule available, and so that more lives can be saved even in other countries too. So now this is the right opportunity for us. In this China, many people will become allergic. I think many people will be looking towards India find Indian molecule products which can do more good to all across the patients. Hope, I think MCure does this and make this brand more broad and global brand. And any final words you would like to say, Dr. Onkar, before we close?
Thank you very much, sir. Thank you very much for your apt comments, sir. And thank you very much for endorsing our brand, sir. And thank you. I express my sincere thanks to you for conducting this program, sir. At the same time, I would like to express my sincere gratitude to all the faculties who have discussed all the nitty-gritties of COVID-19 and how we can consider the thrombolysis as one of the important strategy. Thank you very much, sir. And we would like to collaborate for certain events, future events with you as well, sir.
Thank you. But a company should keep in mind what Dr. Ramesh sir mentioned.
Yes, sir.
Cost is a little less, no? It can be used in more number of patients.
Yes,
obviously,
sir.
we all want patients to get benefited with this benefit of this molecule. But for the cost, it's a wonderful molecule compared to streptokinase. But we are still forced to use streptokinase in some unfortunate poor patients because of only costing issue. I think company is also working towards it, as more and more vials being used. I think the cost should come down further. I think with this we'll close. And thank you one and all. And thanks all the participants also for participating in this webinar and this sharing your thoughts and questions.